Hi again. This is a 67-year-old female patient with an abdominal radiograph to exclude the presence of renal stones. This case has a specific and quick teaching point. In the near future, I'll dedicate a clip on how to read abdominal x-rays. If you're looking for renal stones, you look for stones along the course of the renal collecting system. And you'd expect to see stones over the renal shadow on either side, in the renal pelvis here, or along the course of the ureters as they go all the way down to the pelvis. There are no abnormal calcific densities there, but let's look at the pelvis where we have the urinary bladder. And here you have multiple calcific densities. The problem with the calcific densities is that some of those may represent flibulli. A flibbolith is a calcified small vein, and it typically has a central lucent area with a white area outside. So this here is a flibbolith, which looks different than this calcific density, which is elongated, irregular, and larger in size. And you write if you suspect this to be a urinary bladder stone, compare that to the smaller flibbolith here. And here's the correlative CT on the same patient, showing you that stone in the urinary bladder. The CT also shows that there are these rounded small calcific densities that are outside of the urinary bladder, consistent with flibulli. The patient also has orthopedic fixation hardware from prior spinal surgery and clips here due to a prior cholecystectomy. As I said, I have a specific teaching point. All that is interesting, but I'm aiming for something else. Do you see any other thing that looks a bit unusual? Don't forget that the lungs are part of what you see on an abdominal radiograph. You don't see the whole lung, but you see the lower lungs, and looking carefully you'll notice that you have these linear, highly dense structures. So you have all those linear dense structures in the lower lungs. If you look on the other side, you'll notice the same thing as well. The density of this tubular structure is extremely high, so it's either calcium or something else. If we look more carefully around the orthopedic fixation hardware, you'll notice that you have similar structures adjacent to the spine. Whenever you have tubular structures in the lungs, you have to think about one of two things. They either represent airways or vessels. So back to the coronal CT on the same patient, this is a tubular vessel within the lung, likely a pulmonary artery. It has a normal density that is equal to that of soft tissue without giving contrast. However, this part of the vessel appears very dense. Let's go back and forth, and here's another vessel that does the same thing, a third vessel here. Let's look at the other one on the other side. So this is all dense material within pulmonary arteries. The question is, why did that happen? Your answer to that question is here. We know that the patient underwent spinal surgery, but looking carefully, you'll notice that the patient also has this additional material within the vertebral body. And what you're seeing here is that the patient not only underwent surgical fixation, the patient also underwent what's called a vertebroplasty. With vertebroplasty, there is transcutaneous injection of cement-like material into the vertebral body, classically in the context of loss of height of the vertebral body with osteoporosis to stabilize the vertebral body and decrease pain. Like any procedure, there are a few complications. One of the complications that may be encountered is that the cement squeezes outside of the confinement of the bone and sometimes drains into the perivertebral venous drainage, such as what you see here. Here's a sagittal image that shows the same thing. If you go to the side, you'll notice that you have these veins that drain the cement. And like any venous drainage, this would eventually reach the SVC, then the right atrium, then the right ventricle. And from the right ventricle, the material would reach the pulmonary artery. And as expected, the cement within the lumen of these small pulmonary arteries would eventually get stuck at the peripheral aspect of these vessels. So if you think about it, this is a kind of a pulmonary embolism, but it's not a thrombotic pulmonary embolism. So this is a type of non-thrombotic pulmonary embolism known as vertebroplasty cement embolization. It's a less common complication of vertebroplasty, usually has no consequences, but if the amount of embolization is substantial, the patient might have shortness of breath. Unfortunately, such material would remain stuck within the pulmonary vessels as long as the patient lives. Our quick teaching points from this case is that when you look at the abdomen, you should also look at the lungs. Don't forget that. We also learned a little bit about vertebroplasty and a complication related to that known as cement embolization. So whenever you see very dense tubular material within the lung that could be within the vessels, think about that entity. That's it for today's quick case. Thanks for watching. Your comments are always appreciated, and see you with more cases later. Hi there, this is a 28-year-old male patient with extremely interesting findings of a specific diagnosis. We're looking at a sagittal CT scan of the neck in bone window. This case is more interesting for seniors, but it has lots of neat findings, kind of show and tell for juniors as well. Let's start by the first finding. There is an abnormal shape of the sella turcica. This is where the pituitary gland lives. A normal sella turcica should have a very rounded appearance. However, this has a very unusual configuration. It's flat anteriorly and rounded posteriorly. The flat anterior component, which is normally termed tuberculum sella, and the unusually rounded posterior component, which is called dorsum sella, lead to a J-shaped sella turcica. Another finding is the underpneumatization of opacified paranasal sinuses. Note how you don't have a well-developed sphenoid sinus, which should live here. And notice the opacification of the paranasal sinuses, namely the ethmoid paranasal sinuses and part of the frontal sinus here. Now let's go to the mandible. You'll notice how the mandible is a short mandible. You'll also notice underdevelopment of the mandibular condyle and the temporomandibular joint. You'll also notice unerupted teeth within the mandible or the axilla. This is a good example here within the maxilla. Now to the spine. This really looks unusual. All the spinal vertebrae appear to be flattened. And this is what's called platyspondyle. Not only that, some of these vertebral bodies demonstrate anterior and inferior beaking, which is this pinpointing appearance. The second vertebral body should normally have a long odontoid process, which is not seen. So there is odontoid aplasia. The craniocervical junction looks short, and there is abnormality of the foramen magnum here. Changing to a soft tissue window, you'll notice that the soft tissues around the C1 and C2 articulation are more pronounced than usual. So there is ligamentous and soft tissue hypertrophy around the C1 and C2 articulation. So the spinal osseous and soft tissue abnormalities led to a very important finding. This is the posterior fossa. This is your cerebellum, this is the brainstem, and the spinal cord should descend here. You could already tell there is severe spinal cord compression at the cervical cranial junction here. All of the described osseous findings are collectively called dysosteosis multiplex. And this is a fancy name that's used to describe these osseous changes in the disease known as mucopolysaccharidosis. Mucopolysaccharidosis is a lysosomal storage disease. It's an inherited condition, usually autosomal recessive. There is usually absence of lysosomal enzymes required to degrade something called glycosaminoglycans. And this results in deposition of this material in various tissues, whether osseous or non-osseous. And this results in various manifestations. Depending on the severity and the type of the disease, the patient lifespan would differ. Some patients would die early, however, others would live longer to reach adulthood. As we said, this patient was 28 years old. Let's recap. This is a case of mucopolysaccharidosis with classic osseous manifestations known as dysosteosis multiplex, which include a J-shaped cella, underpneumatized paranasal sinuses, a short and wide mandible, underdeveloped mandibular condyles resulting in abnormal temporomandibular joints, disorganized and unerupted teeth, platyspondyly with aplastic or hypoplastic odontoid, short craniocervical junction with soft tissue hypertrophy leading to compression of the spinal cord. And of course, there are other skeletal and non-osseous manifestations that we don't see here. Before I leave, I'll just emphasize one thing. This beaking of a flat vertebral body is an exam favorite. So when you see beaking, think about mucopolysaccharidosis. Well, that's it for today's case. Thanks for watching, and we'll see you with more cases later.